Good afternoon, and thank you for joining the RLS Foundation's webinar titled Aging with RLS. My name is Adriana Colucci, and I'm the Administrative Assistant at the RLS Foundation. The RLS Foundation is using Zoom webinar for this and all future webinar events. To ensure seamless webinar access, confirm that your Zoom app is up to date with the current software. If you need help accessing the live webinar on your computer, call the phone number listed on the registration confirmation email for assistance. If you have any other questions, please email clara@rls.org. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Richards will answer as many questions as time allows following her presentation. After the webinar, the recording will be made available in the member portal section of our website on the next business day. If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Kathy Richards, a research professor and senior scientist at the University of Texas at Austin School of Nursing. Dr. Richards has conducted sleep research in Alzheimer's disease for over 20 years and received over $25 million in NIH funding to support her research endeavors. Several of her studies have focused on RLS and related symptoms in older adults with Alzheimer's disease and related dementia. One of her current projects is called Night Rest. It focuses on the identification and treatment of RLS in older adults with dementia. It also explores and characterizes linkages between RLS and nighttime agitation. Another project focuses on ways to identify RLS in older adults with dementia using an accelerometer. Dr. Richards serves on the Foundation's Scientific and Medical Advisory Board and is a member of the Research Grant Committee. Dr. Richards, we thank you for sharing your time and your expertise with us today. I now invite you to begin your presentation.
Okay, I hope everyone can hear me. Please let me know if you can't, or let Adriana know. I want to first begin by thanking everyone for coming today or joining by webinar, and thank you to the RLS Foundation for inviting me to come and share a few things about being an older adult and about aging with RLS. So all of us forget things. We might forget where we park the car at the grocery store, or where we put our iPhone, my favorite thing to forget, or a name of a classmate. But those things that we forgot, that we might consider minor inconveniences in our 20s, 30s, and 40s, to get a little older, those can be more ominous and maybe more frightening to each of us. And we might worry that this forgetfulness and losing our iPhones might be Alzheimer's disease or dementia. Might be quite serious. So we're going to talk about some of those things today in the context of RLS, and I hope they're helpful to you today. So we're going to talk about aging well. What is aging well, and how might we do that? I'm going to talk frankly about cognitive aging and what it is and what it's not. I'm going to talk about some healthy steps that we can do no matter how old we are to preserve our cognitive and physical health and mental health, and talk about also sleep in older adults and how sleep as we age and the changes that occur with sleep as we age interacts with restless leg syndrome, and also special circumstances that occur in older adults. And just because Persons with RLS get older, just like all the rest of us. Persons with RLS, aging persons with RLS, and special circumstances that occur in them, such as dementing illnesses like Parkinson's disease, Alzheimer's disease, and related dementia, and also hospitalization, which I always talk about because some of my oldest work was when I was very young, as you can tell, it wasn't just yesterday, was about sleep and hospitalization. And then finally, I want to talk about clinical recommendations for treatment. I'm going to spend more time on non-pharmacological recommendations than pharmacological recommendations, because I figure that you probably hear quite a lot about those in these presentations. And lastly, I'll answer questions. So, Maggie Kuhn, I don't know if you remember Maggie Kuhn, perhaps not, but she was the founder of an organization that came about in the 1970s called the Gray Panthers. The Gray Panthers are still around, and it's an advocacy organization to prevent ageism. And let me see, I have a chat. I'm not sure if someone's trying to say something to me, but I'm not seeing it if you are. Anyway, so this is what Maggie Kuhn had to say about aging, her myths, that it's a disease, a disaster. It's not that. That we're mindless. No. We're sexless. No. They're useless, and that we are powerless, and that we are all alike. While we are definitely not all alike as older adults. So we're all different, and we are all unique, and we all are aging different ways and different times. Getting older is inevitable, as we know, and certainly better than the alternative. While we can't control our age, we can all make good choices so that we can be as healthy as we possibly can as we get older. So one of the titles of this talk is Aging Well. So I want to define what is aging well. So aging well is defined as the ability to maintain a low risk of disability. So what is disability? I've got two abilities in that sentence. Disability is I guess being a time of when a person has limited movement, such as limited ability to walk. So that's a disability. Limited senses, such as hearing loss, is a loss that we have as we age. And then limited ability to maintain your activities that you enjoy in your life. So a low risk of disability means that you're aging well. And also aging well is defined as a high mental and physical function and an active engagement with life. So David Bowie is, and I may not remember him either, but perhaps you do if you're an older adult, but he's rather quite a famous English songwriter and actor, and one of the most influential musicians of the 20th century. He said, "If you're pining for youth, I think it produces a stereotypical old man because you only live in memory. You live in a place that doesn't exist." He says, aging is an extraordinary process where you become the person you always should have been. So I think that's something to aspire to, becoming the person we should have been as we age. But I will say that in reality, each of us experiences aging quite differently. So what is age-associated memory impairment? What is cognitive aging? So we may have difficulties remembering things on occasion when we have age-associated memory impairment, which is normal. That's a normal thing that happens to all of us. That means we forget a password for a website or a name of a former classmate, or as I mentioned earlier, our car in the parking lot of the grocery store. That doesn't mean you have dementia. That's a normal part of aging, and we all have it. So will your memory get worse as you age? I think that's a fear of all older adults, all of us with and without RLS. So about 40% of us have some form of memory loss that's more than this normal cognitive aging after 65. But if we do, the chances are very unlikely that memory loss is related to dementia. The good news is only 5 to 8% of us will live with dementia after the age of 60. So I think that's good. So there's something in between this age-associated memory impairment that we all have, that I have, anyone over 65 starts to have. There's something in between that and dementia. And it's a condition called mild cognitive impairment. What is the difference between mild cognitive impairment and dementia? So mild cognitive impairment is memory loss and other symptoms such as difficulty speaking, difficulty getting out what you want to say. But these changes are not so severe that they interfere with your daily function and your routines. You can still function as usual with list, with text to guide your speaking, other things. But it's this place in between, this normal memory loss that does happen with aging, this mild memory changes, and dementia. So that's mild cognitive impairment. Now let's talk about dementia. Mild cognitive impairment can worsen and become dementia. Dementia is memory loss that is severe to the point where it's affecting your daily life and your routine. You find it difficult. You will find it if you have it, difficult to learn new things. And you find it difficult to complete tasks that you're familiar with. One example is just suddenly you find that you can't drive somewhere that you have been going all of your life. It's a usual place. It's your work, your daughter's house, somewhere, and you can't get there anymore. And that's an example. You find it difficult to complete tasks that you're familiar with. And then often that's when others close to you start to notice these changes in your abilities, and they may say something. If there's one thing you remember about my presentation today is this: the only way to know for sure if you have dementia is to talk to your doctor and be tested. And I encourage you to go to a neurologist who has expertise in Alzheimer's disease and dementia for these testing. And also, of course, talk to your primary care provider. But we have very sophisticated testing. We aren't able right at this point to cure dementia, but we can quantify it very precisely. And the best way to do that is to go to a doctor who specializes in care of people with dementia. It's important to note also that some people have dementia-like symptoms, but they don't have dementia or Alzheimer's disease. And that is why it's so important to go and get assessed if you have some dementia-like symptoms that you're concerned about. Some of the causes of dementia-like symptoms that are not Alzheimer's disease are depression, untreated sleep apnea. I'll talk a little bit more about that. Delirium, I'll talk quite a bit about that. Some side effects of medications that you're taking. Lyme disease, a less common, but still a potential cause. Thyroid problems, especially in women. Certain vitamin deficiencies. An example of this is a physician that I knew some 20 years ago, very good primary care physician who thought he had dementia and was actually considering stopping practicing because of that. And he followed up, as I would suggest that we all do if we're concerned, and he had a vitamin B12 deficiency, and he is still practicing today. because he had that treated. And then also alcohol consumption that's excessive. I would encourage you, these conditions can be reversed with treatment. That is why I want to tell you about them, and to encourage you to follow up if you think you may have some symptoms of dementia or early symptoms of dementia. I would also encourage you to go to the Alzheimer's Association website. Every year they publish the facts and figures regarding Alzheimer's disease. There's one for 2023. That's excellent. I look at it every year because there's always something, even though I'm in the field, that I learn by reading that. So some advice about aging well and for all of us, with or without RLS. Be active every day. Walk, stretch, strengthen. For my own self, I like yoga and walking, and it just helps me so much to be healthy, to go to yoga. It also involves meditation, which is also another helpful thing to keep your brain active and healthy. Improve your diet. Most of us eat too many processed foods, and one way to know what's a processed food is, does it come in its own wrapper? Apples, for example, come in a peeling. That's its own wrapper. So eat less processed food, eat less sugar. There's a lot of data showing sugar and relationship between excess sugar intake and Alzheimer's disease. Consider a plant-based diet. I do not do a completely plant-based diet, but I have tried to cut back on meats, which is another thing you can do. Again, always check the wrappers of things, find out what's in there that you eat. Stop smoking if you smoke. Change your brain, challenge your brain. It loves it. Our brain is very plastic as we age, and at all times, learn a new language. If you can, try that. Drive a new route somewhere that challenges your memory. Learn to play an instrument. There's so many things to challenge your brain, and that will help keep you healthy. And then what we're going to focus on more today is get quality sleep. Lack of sleep affects our memory, our emotions, our weight, and even our appearance. So address snoring, address RLS, address medication side effects, and any underlying medical conditions that interfere with your sleep, such as acid reflux and depression, stress, and prostate problems in men that will wake you up at night. And lastly, play some. My mother loved George Bernard Shaw. He said, we don't stop playing because we grow old. We grow old because we stop playing. So have some fun. That will help to keep you young and keep you aging well. So let's talk about sleep now. So the average sleep need is, as an adult or anyone, an older adult, is 7 to 8 hours. Fewer than 6 hours and more than 8 hours is associated with cognitive decline in older adults. So try to keep that magical 7 to 8 hours. Normal sleep latency, which is how long it takes you to fall asleep, is 10 minutes. And normal sleep efficiency in normal adults, not older adults, in normal adults is 95%. That simply means that you're asleep for 95% of the time that you're in bed and trying to sleep. However, sleep changes with age. The sleep efficiency is worse. It drops 80 to 85%, takes us longer to fall asleep. We have longer and more nighttime awakenings than we do as a younger adult. We have decreased slow wave sleep, and there's quite a few investigators in trying to understand if we can increase slow wave sleep in older adults, if it improves our memories, the memories. So slow wave sleep is important for memory consolidation and processing of memory. In older adults, in younger adults is about 20%, and it drops to only 5 to 10% of sleep in older adults. And also the amplitude of these slow waves decreases in older adults, which is another interesting change. And then older adults are early to bed and early to rise, as we know. So what are some causes for sleep problems in older adults? Well, one is changes in the sleep-wake centers of the brain. Amyloid begins to be deposited in our brains early in our life. It gradually increases And one place it's deposited is in what's called the suprachiasmatic nucleus, and that is the sleep-wake center of the brain. It's the clock that keeps our sleep and wake separate from one another, and it is sets the time for our sleep-wake centers. And so it starts to have some age-related changes too, even if we don't have dementia or mild cognitive impairment that I mentioned earlier. So that's one of the reasons. And then we have this problem. Older adults, and I just got back, I was telling Adriana, I got back from a high school girls trip to the beach. All of these are friends from high school, and I've already had my 50-year high school reunion. So we're all getting on up there. And we talked about being awakened at night just because, or not being able to fall asleep because we are stressed about things, we worry about things, we think about things that happened years ago that we wish we could change, things about our families, our health, worrying about things, grief and loss, and this thing that seems to be more common in older adults, that my mind just won't shut down at night. And I don't have this in the presentation, but I used quite a few tricks about that to take care of this mind racing and not shutting down at night. It's part of cognitive behavioral therapy, and I just want to mention it because I think it's so important. some things, and I do talk about cognitive behavioral therapy later. I would highly recommend it, but there are some other tricks that you can do to shut off your mind at night. One is simply deep breathing exercises, and you just keep on doing them, and you concentrate, and it will stop those thoughts. Is taking a breath in, counting to 4, holding it for a count of maybe 1 to 2, and then taking a slow breath out, counting 1, 2, 3, 4 as you breathe out. If you keep doing that, that will often shut your mind down. Another trick that I personally found really helpful is thinking about this special moment in your life. For me, it's when I held my children for the first time. And that was such a warm, wonderful feeling that if I can focus in on that feeling, it will cut that mind, shut that mind that just won't stop it and shut it off. But there are many tricks like that. And I would encourage you, if you are experiencing that, to read about those. You can Google it and learn some of those. And you can also go to a sleep physician for cognitive behavioral therapy. Chronic health conditions or other causes for sleep problems in older adults, pain and discomfort and depression. And then medications are common. I'm going to talk quite a lot about these. I'm going to go over them quickly now. Steroids, like theophylline, some antidepressants, particularly like Elavil, those kinds of drugs. Cold medications, one of the most common and over-the-counter drugs is diphenhydramine, and we do not recommend that for older adults. Medications for Parkinson's disease, breathing medications like theophylline. So those are just a few, but there are so many that interfere with sleep in older adults. And then underlying sleep disorders, insomnia, obstructive sleep apnea, I've already talked about, and of course, restless leg syndrome. So we all are here because we're interested in restless leg syndrome, but quickly, I'm going to do a quick defining of it. It's uncomfortable leg sensations, sometimes described as painful. The disorder is associated with the urge to move to relieve this leg discomfort. Discomfort worsens in situations where you can't move, such as on an airplane or bed rest. Disturbs sleep mostly in the first part of the night, and it's more severe and prevalent in older adults. It's unclear why it's more prevalent and severe from a biological perspective. But from a behavioral perspective, it's likely that age-related sleep changes and coexisting sleep disorders exacerbate RLS, and having RLS exacerbates sleep changes and sleep disorders that may occur in aging. So that's, I think, the generally accepted hypothesis about why. And so what to do? So here's some best sleep tips for older adults and certainly works for all of us. Establish consistent sleep and wake schedules, even on weekends. And that's part of in training that circadian clock that I mentioned, the suprachiasmatic nucleus. It doesn't work as well when you get a bit older. So it's training it. And then a good bedtime routine, such as listening to music, reading, but not in front of a screen, reading a magazine. I would avoid screens within an hour of bedtime. Whatever things that relax you and help you get prepared to sleep. I like chamomile tea, so that's mine. And you begin this an hour or more before the time you expect to fall asleep. A good environment, dark, quiet, cool. I think a cool environment is really important. As you age, somehow we seem to be hotter. I don't know why that is exactly. And then, of course, pillows and mattresses. Finish eating at least 2 to 3 hours before your regular bedtime. Exercise, but not within 2 hours of bedtime. But that might be different for persons with RLS. For when you have a bad RLS night, walking, and you might need to exercise closer to bedtime. No caffeine after 2 p.m. and no alcohol within 2 to 3 hours of bedtime. And then limit or no alcohol for those that are experiencing severe RLS. I would encourage you to observe RLS symptoms after you drink different alcoholic beverages. I've noticed myself that certain wines have different tannins and they affect my legs in different ways. So just be observant of what, if you drink alcoholic beverages, which ones may seem to worsen your RLS. I would encourage you to keep a daily diary of your RLS symptoms, what you did, what you ate, what you drank, to try to take control of your RLS and what things that are common that you might be doing that worsen or improve those. And then if you can't fall asleep, or go back to sleep after wake up after a while. You've tried all Kathy's tricks and lots of others that you will learn after this presentation from the website, from the Googling, and you probably know them already. But don't fret about it. Just get out of bed and read again, not on the screen, and try again when you're sleepy. So some general RLS treatment guidelines I want to share. The high prevalence of RLS requires that primary care physicians, your primary care physician knows about RLS and takes a role in management. So I would say that if your primary care physician doesn't know about RLS, I would find another one. There are many that do. And so find one that really wants to help you manage your RLS. Of course, iron status, I think most likely all of you know that iron status is very important. It's very much connected to RLS symptoms, and we want to have your primary care physician should be assessing that regularly and be considering with you iron replacement therapy. And also managing any coexisting sleep disorders and considering the role of medications in causing or worsening RLS, medications that you're on. So the current buzzword in older adults is deprescribing medications, and consider whether you and your healthcare provider should consider whether certain medications that you are already on, like antidepressants, neuroleptic agents, antiemetics such as clopramide, or sedating antihistamines, and I've mentioned those quite a lot already. Diphenhydramine is the big one, maybe contributing to your RLS, and whether just discontinuing those is possible. Other sleep disorders I've already mentioned, such as sleep apnea, which is more prevalent as you age as well, may exacerbate RLS. Clinicians should inquire about other sleep disorders, particularly RLS, and pursue testing. In some cases, sleep apnea treatment might improve your RLS. Patients with RLS may have other causes for insomnia. I think I've mentioned some already. Depression is one, anxiety, our behavioral, excessive caffeine intake, and these may need independent treatment. Chronic health conditions, optimizing treatment of any medical conditions that symptoms that negatively impact sleep, such as pain or nocturia, may help your sleep and perhaps your RLS. And then pharmacotherapy that's tailored for certain any neurologic or psychiatric disorders that you might have, as long as the risk-benefit profile is favorable. As we all get older, it's very important to look at the risk-benefit profile, because some medicines cause dizziness, for example, and falling can be harmful to us as we age. Of course, and at any age really, but more so when we age, when our bones are not as strong. In general, for older adults, this is important to know. Fewer medications and lower doses are better because of interactions and side effects. So some RLS specific recommendations. Mental alerting activities such as video games, crossword puzzles can help at times to reduce RLS symptoms. Consider abstinence from caffeine and alcohol. I've mentioned iron, and then intermittent use of the following medications: carbidopa, and low potency opioids. For chronic persistent RLS, treatment should start with the alpha-2 delta ligands, and again, gabapentin is one. Gabapentin inacarbal is another. Unless patient factors suggest a dopamine agonist would be safer. Some things that would favor a dopamine agonist would be obesity and complications, depression, gait instability, because some of these alpha-2 delta ligands can cause some dizziness, anything that causes respiratory failure, history of substance abuse. So if RLS is present for much of the day and night, you might consider the use of a slow release preparation, such as, again, gabapentin inacarbal, unless there's a contraindication. And then if those alpha-2 delta ligands are ineffective or not tolerated, change to dopamine agonists. 300 milligrams is recommended in patients older than 65 years of age at 5 p.m. And adverse events should be carefully monitored. Some of those are daytime drowsiness, dizziness, unsteadiness, cognitive disturbances, and these can be more frequent in older patients, as well as some of the more common edema, weight gain, and these should not be given if a person has a history of suicidal thoughts or ideation. Their alpha-2 delta ligands are contraindicated in that case. Sometimes they can cause respiratory depression, especially when they're used in patients with underlying pulmonary diseases. And there is some increased abuse potential in patients with a history of substance use. And then the wonderful thing about the alpha-2 delta ligands is they can provide additional benefit to patients with chronic pain, insomnia, and anxiety. So some things about management of RLS and in combination with age-related insomnia. Non-pharmacological multi-component interventions are always recommended, preferred over pharmacological treatment for insomnia. Cognitive behavioral therapy, I've mentioned, it's highly, highly effective, and it requires a little time and effort to learn to practice it, but you can learn all about it by going to a sleep disorder specialist, and a lot of psychologists also provide cognitive behavioral therapy for insomnia. Bright light, I highly recommend it. It's part of cognitive behavioral therapy. Get about an hour a day. I would encourage sunlight if possible with a little sunscreen on. And then social activities have been shown to being socially active improves insomnia, improves your sleep. And then exercise, I've mentioned over and over again, such an important thing for us all to continue as we age. And then yoga, I've mentioned, it really helps me. I don't know what I'd do without it. And then Tai Chi, there's a lot of good data on Tai Chi lately and how it can help with insomnia. And then melatonin has been used in older adults and seems to be safe. And then some other acupressure massage. So medications are, we try to avoid them for insomnia in older adults. A lot of them are on the list called the Beers list, which is a list of potentially inappropriate medications to use in older adults due to potential risk outweighing benefits. So for the treatment of insomnia, medicines on the Beers list that are potentially inappropriate include all the benzodiazepines, the GABA drugs, and the selective the Z drugs, including zolpidem, Zaloplan, antihistamines such as diphenhydramine, which I keep mentioning, please don't take that, and antipsychotics, except for treatment of schizophrenia or bipolar. So those are on that list to be avoided in older adults. Hypnotic agents not included on the Beers list include melatonin receptor agonists and low-dose doxepin, although higher doses on the Beers list, and off-label use of antidepressants and anticholinergic depressants are on the Beers list, while low-dose trazodone is not on the Beers list and might be helpful. Orexin receptor antagonists are also not on the Beers list, but they're pretty new. And the practice of using antipsychotics for sleep disturbances in older adults with dementia is fallen out of favor because it causes strokes and other adverse events. So not recommended. So what is nighttime agitation and sundowning? That's increased behavioral problems in persons with Alzheimer's disease and other dementing illnesses during the evening and night. So my research of 25 years has shown that RLS is very prevalent in older adults with dementia. And there's some connection between nighttime agitation or this sundowning syndrome and RLS. And it's likely because RLS is not recognized in older adults with Alzheimer's disease. It's very hard to diagnose it. And it's very important that healthcare providers, older adults with dementia, recognize that one of the causes of this sundowning syndrome, this agitated behavior that is very distressful for caregivers, might be RLS. So because of, it's hard to identify RLS in persons with dementia. As you know, RLS is diagnosed by an interview with a sleep disorder specialist, and that specialist would ask the questions, this diagnostic criteria, and determine whether or not a person has restless leg syndrome. Well, people with Alzheimer's disease and dementing illnesses cannot answer questions about their symptoms, about what makes it worse, what makes it better, what do your legs feel like? They aren't able to answer those questions. So diagnosis of RLS has been really difficult in the past. So that I set about over the last 15 years, identifying a very reliable, valid, sensitive and specific measure to diagnose RLS in persons with dementia. We have that measure now, and we are also now further testing some other equipment measures. So this, your provider can determine if someone has RLS and has with dementia now. We have that. So there's no reason for providers not to consider that RLS might be causing nighttime agitation. There's ample evidence that it often goes together and it might be a cause. Certainly, it's just common sense because older adults have RLS and it just doesn't go away when someone has developed dementia. So just about hospitalization quickly, because all older adults typically are in hospitals. They're the most likely people to be in hospitals, and hospitals aren't conducive to sleep or to RLS. Hospitals often being in the hospital and being critically ill or very ill results in something called delirium. And that is something that looks very much like a dementia, but it is usually short term, but you don't want to develop it because these symptoms can continue after hospitalization. There are some long-term consequences, psychiatric disturbances, long-term and short-term memory changes, and delayed recovery from illness. So one of the causes for delirium is sleep disturbances, and the hospital and sleep disturbances happen all the time in hospitals. I think all of you would raise your hands that if you've been in the hospital, you haven't slept well. So patients have to advocate for their own health in hospitals. So these are the things that I would recommend that you as a person and your family advocate for you if you are in the hospital. Uninterrupted sleep times at night. They need to give you some time without going in every 5 minutes so that you can have some sleep. Naps and uninterrupted napping times. A 2-hour nap can help you to keep up with that sleep. Blood draws no early than 6 o'clock in the morning. They still draw blood in many hospitals 2, 3, 4 o'clock in the morning. Limiting visitors if you have to have sleep, and a quiet environment at night. If it's noisy, complain. They should provide you with earplugs if you want them, an eye mask because it is a little bright, and they should be dimming the lights. Patients and families must advocate for better sleep. Ask when you are in the hospital or as a family member, what will be done to help me sleep? Ask the doctor, ask the nurses, what time will lab and x-rays be done? And you should tell them, I don't want these done before 6 a.m. It's too early, I want to sleep. You want to be sure that you know how they control noise. Reduce noise, reduce interruptions to sleep, control your pain while you're there, get you up as soon as possible. And they need to know that you have RLS, obviously. Anyway, so these are some things that might help you in the hospital. Some interventions, others, music, earplugs, white noise, eye mask, avoid Benadryl at all costs, and benzodiazepines. Lastly, I'd like to finish with answering this question for all of us. How do you know you're getting enough sleep? Well, these are what we commonly what we say. I'm going to look at my watch here. I've got just enough time to go over this. Some daytime indicators. How do you know? You feel rested and alert in the daytime. You don't need huge amounts of caffeine to stay awake and to function. You don't need food, especially carbohydrates, bags of potato chips on your desk to stay awake and alert in the daytime. And if you're getting enough sleep, you don't fall asleep at unplanned time. You don't have unplanned napping. I mean, I think it's okay. Sometimes all of us might nod off if we're super tired, but if you shouldn't just be nodding off often and unplanned, certainly not when you're driving. So be very careful of that. We'll warn you about that. And then sleep indicators to fall asleep within about 15 minutes at the usual bedtime. Few or no awakenings. If you wake up, you can fall back asleep pretty quickly, and you don't have loud snoring, breathing pauses, or shortness of breath. And that is the end of my presentation. I'm going to just let you read this. One of my favorite singers is Cher, and this is what she had to say about getting old. And I'm going to now stop and be ready to answer your questions. Adriana, are you there or have you fallen asleep?
Not at all. Thank you so much for your very thorough and your informative presentation, Dr. Richards. I'm not asleep at all. We will now be answering some of the questions that were submitted during the registration process. All right, so the first one is, are there different medications and behavioral treatments used for nighttime agitation in people with dementia and RLS?
Yeah, I think So this is still a very, new field, and I congratulate you on asking that question. I think that it would be a very individualized approach to persons who have nighttime agitation and restless leg syndrome. I think that because persons who have nighttime agitation due to Alzheimer's disease are older, so that should certainly be considered for a provider that's trying to decide how to treat that. I personally think gabapentin used off-label would be a good treatment. But again, the issues of dizziness and would need to be carefully addressed, and then also other symptoms. So it would really require a very careful, I guess, collaboration between the doctor, the healthcare provider, the family, the caregivers of that person with Alzheimer's disease, and the person with dementia, as much as they're able to be. So I guess my first thing to say is certainly iron is your first treatment of iron deficiency. Iron deficiency, I didn't talk too much about. It was very common in older adults. So that's the first thing we would recommend before going to, the alpha-2 delta ligands. I would always recommend that. Second thing I would recommend is what this deprescribing, and what that means is, again, looking for medications that might exacerbate RLS, that the dose could be lowered, which is very, very, very important. So I would recommend that as a second choice of treatment. And then also treating any coexisting illnesses, problems, health problems that might be exacerbating RLS or exacerbating insomnia. So that very well-rounded approach is what I would recommend. Okay, thank you for asking that question. A very good question.
All right. Are geriatric care providers being educated about the care and management of patients with RLS?
Well, I think we're making strides in that direction. Again, of what I would tell you, if you, for all of you, I would imagine most people here on this call have RLS, or either a loved one or family member has RLS. I would find a geriatric care provider, if you're an older adult, that is familiar with RLS, and ask about that question. Be sure they understand it and are familiar with it. I go to geriatric symposiums at geriatric meetings often, and there are presentations on insomnia with some short little snippets of it on RLS. Not nearly enough. I think there needs to be a lot more. It's not only, it's intensivist too, and that means people taking care of us who have all of us when we're in the ICU. So all physicians, need to know more about it so that we can be a lot more comfortable and have less discomfort, less pain, and recover better from health conditions as we get older.
Agreed. Next is, do you think RLS causes neuropathy of the feet as people age?
Well, that's an important question, and I actually looked that up to try to do a little reading beforehand. I think there's definitely an interaction and an association, if you will. The two are associated, neuropathy and RLS. As to whether RLS causes neuropathy, I really don't know. And that's a lot more difficult as a scientist to determine whether RLS causes neuropathy or if they just co-occur. So there, what would be required would be some kind of clinical trial. And obviously we can't randomly assign someone to RLS or no RLS. We can collect a lot of data over time and eventually perhaps get a better understanding of the two. But an interesting question, a very good one. Sorry, I can't answer it conclusively.
Does having RLS lead to a higher chance of having dementia or sundowning syndrome?
Oh, that's a very good question too. So there are a couple just 2 studies, and I think only about 2. Last time I looked was just a few weeks ago, that show that there's some relationship between having RLS and later having some kind of dementing illness. But I think the evidence is pretty sparse at this time. It's pretty sparse. A lot of people are trying to find as many things as possible that might relate to, be a cause for Alzheimer's disease. So, I mean, the evidence is weak at this point that RLS, very weak, very, very weak, that RLS is a cause for, dementia or Alzheimer's disease. However, just the simple knowledge that, gee, there's a lot of people. I mean, the data vary, but it probably at least, I would say 20% of older adults have RLS, whether it's very mild or whether it's severe. That's just, that's a pretty educated guess, and the data pretty much support that, although there's a lot of different datas that vary a bit, on the up or the downside of that. So definitely people who have dementia have RLS. Plus, as certainly as we age and we may or may not have dementia, there are other things that happen to us. Most all people with Alzheimer's disease are put on antidepressants. Some antidepressants, if you have a super mild RLS, worsen it tremendously. So I think that there's a chance, it's just obvious that people with Alzheimer's disease and dementia have RLS. They have it at the same prevalence that any older adult will have it, perhaps even greater, because they're often on antidepressants. They more frequently have iron deficiency because sometimes they may not eat as well. So I think it's more likely that it's slightly more prevalent in them, but I do not believe at this point, and the evidence does not support it, that RLS causes dementia.
So definitely a lot of questions surrounding RLS that require further research. So the next question is, how do Alzheimer's patients deal with RLS?
Well, one of the things I think they do is get up and move around. They pace and wander. And that's, I believe, often to relieve the symptoms. I mean, the danger comes about when persons with Alzheimer's disease pace and wander and leave the safe environment and get lost, of course. So that's, a danger for persons with Alzheimer's disease is getting lost outside, getting hurt because they escaped from the house. So, or the nursing home or an assisted living facility. So I think they also might yell and scream because they know they're uncomfortable, but they really may not know why. So healthcare providers should be looking for signs of RLS, rubbing the legs, for example, moving the legs a lot. So I think it's, and again, another thing, if we know that older adults are prone to RLS, we know that older adults with Alzheimer's disease are going to have RLS. So a trial of a medicine like gabapentin might be indicated if a person has some indication of RLS at a very low dose to see if it does improve their symptoms. So that might be something that I would recommend in certain cases when it appears that they're having symptoms of RLS, but you can't do a definitive diagnosis. You maybe don't have the tools, you don't have the actographs, you don't have the instrument that I developed available to you. So I think a trial might be indicated in some cases, but that's my opinion.
How do various RLS medications affect the elderly different than they affect younger patients?
Well, again, I think that less is more in older adults. For every medicine, we try to keep the doses as low as possible for many reasons. But I think the clearance of drugs is just slower in older adults. So that's the main thing I would say, is that you actually may need fewer medicines for your RLS as you age, may or may not, I don't know that, but the side effects may be greater. So it's a little more challenging, I think, to manage RLS as people age. So potentially fewer, lower doses would be what I would say. And again, back to what is it? What are the things that worsen RLS? People with Alzheimer's disease are routinely, almost immediately put on certain antidepressants that will, some of them worsen RLS. So it'd be very important to know which ones do for a healthcare provider and their families too. You can look it up pretty quickly and be certain that that if depression is treated, that it's treated with a medicine that doesn't worsen the RLS. So those are just some recommendations that might help.
Are low iron/ferritin levels more common in older people compared to the younger population?
Absolutely. That's an unequivocal yes.
All right, and then last question for you here. What research are you currently working on?
Well, we were just finishing up this 6-year project that has been going on even before that for many other projects on RLS and Alzheimer's disease. We're analyzing the data now, and we hope to publish the results certainly in the next year. We don't know exactly. We do have some very good findings showing that we can improve agitation behaviors by treating RLS in people who have RLS and have Alzheimer's disease. We also can clearly say that we believe it's very prevalent, but again, very difficult to diagnose in them and to absolutely know for sure, because they can't answer questions. So that study we're finishing up right now. We're also doing another trial. It's called a pragmatic clinical trial of sleep in people with dementia, and many of whom probably have RLS. We in that trial we're doing an activity. I mentioned a lot of times in my talk about exercise and walking and moving and sunlight. So treating things that exacerbate sleep in people with RLS, which I did mention earlier, is very, very important. So it's not only treating with medications, it's just treating that insomnia that goes along with aging, those sleep disturbances that can worsen RLS. So it's just kind of a vicious cycle, and we have to look at it holistically in persons with RLS as we age, and then as we hopefully few of us, but some of us will develop dementia.
All right, well, thank you so much, Dr. Richards, for your time and your contributions to the foundation. For all of our participants today, if you have any further questions or you need resources on specific topics, please reach out to info@rls.org. That's info@rls.org, and we will be happy to share some of that information with you. Our next webinar will be held on Wednesday, May 17th at 2 p.m. Central Time. Dr. Philip Becker will be discussing causes of RLS. So visit www.rls.org to register and attend. Thank you to everyone who attended today's webinar and have a great day.